that one by one. Good morning. Good morning, everyone. I think we'll go ahead and get started. I think we'll probably have a couple more people who will filter in, but let's go ahead and get underway. So be sure you get some food. We have an array of healthy and not healthy, so you can get some of both and feel all right about it, I think, right? So there's plenty of food, please help yourself. My name is Mindy Fuller, and I manage the Medical Home Portal website, and I also facilitate this meeting. Most of you know me, and if you don't, welcome. We're happy to have you here. We'll start with some housekeeping, and we have several kind of quick announcements or presentations, if you will. So let's go ahead, though, and begin with our introductions. So, Margie, do you mind starting? As I do this every time, the person who's just taken a bite, I ask to start. Margie Alts from Utah Valley Pediatrics Geriatry Office. I'm the care coordinator.
Mindy Betters from Utah Valley Pediatrics Provo Office and the care coordinator.
Jeanette Tingy, Utah Valley Pediatrics Plaza Office, care coordinator.
Rachel Glauser, primary children's case management. Deborah Tober, visiting pediatrics staff.
And be sure and speak up so we can all hear you, if you don't mind. Okay?
University of Utah.
Also, the university. Can you tell me your name? Tiffany and the
Oh, sorry, Craig.
Okay.
Yeah, sorry.
And then pediatrics?
Oh, no, it's an infant right now.
Oh.
It's hard to hear that.
It is hard to hear, yeah. Sorry, guys, you're going to be put on the spot here just a little bit. So, yeah. Do you mind mentioning the...
It's called the Intensive Outpatient Clinic. It's a new population health for Dr. Peter Ware.
And it is adult.
Right now, I mean, we're kind of identifying our patient population, and adults need to be the main focus, but I think we're looking at it.
Okay. And I think what we're interested in right now is kind of that transition from pediatrics. So I'll be honest. These guys are here because of our topic of transition to adult care today, and so we're really pleased that they're here. We don't want to put them on the spot and make them feel uncomfortable, but yeah, we're pleased that you're here. Can you remind me your role? I'm the nurse care manager. You're the nurse care manager. Just take a bite. Ken Bloom from UPIC.
Garizar Goshi, QI coach at UPIC.
Kimberly Manwaring, medical support specialist at the developmental office. Jill Connor, I'm trainer counsel for children.
Carol Hill, Office Pediatrics Specialist.
Margie Kimball, Office Pediatrics Specialist.
Ken Bofer, I'm the care manager at Memorial Pediatrics.
Dan Braun, I'm the behavioral health coordinator at Office Pediatrics.
And Marilyn Helm, Integrated Services Children's Special Health Training Program. Claudia Fruin, Medical Director of Children's Special Health Training. McBride, Editor.
Okay. Yeah. Okay. That's enough.
I'm Heidi Bates. I'm the new nurse case manager for or care manager for the feeding clinic for the youth.
Welcome.
I'm Rebecca Barker. I'm the care coordinator for University of Utah.
Baltimore Integrated Services Program. I'm Keith Burry, Business Development Coordinator with Integrated Services Program. Hi, Eric Christensen, Children's Special Health Care Team, Integrated Services Program.
I'm Maria Castro. I'm one of the care coordinators for the University of Utah Health Care Clinic.
I'm one of the pediatric care managers for the University of Utah Health Plan.
I'm Katie Ames. I'm the I'm Kat Rowe, I'm pediatric care manager with Select Health Pediatric Commercial.
My name is Adam Beeson. I'm the care guide at Public Clinic Pediatrics.
And Jimmy Allen, care coordinator as well as pediatric medicine.
Yeah, of course. My name is Kaylee Everson. I'm the lead community liaison at Healthy Great.
Wonderful. Okay, welcome everyone. All right, so as I mentioned, we just have a few things to do this morning, to mention this morning. So for those of you who have already responded, we have a newish policy about sharing our information so that we can in fact share it with each other, as well as a select number of organizations who will potentially ask to use it for what we will vet as an appropriate care coordination use to further the efforts that we're all trying to do. So if you have not been sent a link to our directory, and that's the way you get access to it, it's because we haven't gotten your okay and your contact information. And I think that, Kay, did you bring some little half sheets? So you can fill out one of those sheets today if you haven't already, or we can contact you. You can ask us via email, and we'll get that information back to you that you'll need to fill out and agree to, and then we'll make sure you're part of that directory and on that have that link to it. We'll try and keep that updated pretty frequently. So that's our approach and our way to make sure that you all know how to get in touch with one another. And then the other part of that is that certain organizations may get to have access to that. But again, we'll only do that once we feel comfortable that they are going to be using that information appropriately. So this is where we have these guys come in. So I'll actually let them do most of the talking, but Jared Piper and Thomas Ghost are MBA students at the University of Utah, and they're part of a project that we're working on right now with Mental Health Portal. And so we're hoping that you'll be willing to give a few minutes of your time to them potentially this week. So do you guys want to come up and talk to me for a second?
All right. Hello, everyone. I'm Thomas Ghost. This is Jared Piper. So basically, what we're trying to do with our project is evaluate the impact and the value that Medical Home Portal brings to different groups. So this is the primary care provider, families, as well as care coordinators. So this week, we would really like to just focus on reaching out to care coordinators, to all of you. If you have a few minutes, we have some questions that we would like to ask about using Medical Home Portal, the value that you have found from it, or maybe even some feedback that you have for the website, things that you could see improved, or features that you would like to see.
Yeah, and the overall goal is that will just really help Medical Home Portal have a bigger impact and hopefully become a little bit more sustainable moving forward. So that's the overall goal.
Yeah. So I don't know after this or what, how to kind of reach out or get in touch with everybody. I don't know the infrastructure, being able to get everyone's information, or maybe we can send out our information. I don't know how
I think that probably makes the most sense. You guys are all right with your telephone numbers and email addresses. We can send that out as an email to the list after this meeting, and ask folks to go ahead and contact you. We're looking at about a week's time frame, right?
Yeah, from today until next week. And we prefer phone call, something that's a little bit more personal than just an email with like a survey type thing. But we just have a few questions that we'd like to discuss over the phone with you. So.
Maybe 15 minutes.
Oh yeah. Not many questions at all. Just kind of understanding a little bit more about what you guys are doing. So. Perfect. Thank you. We're going to be observing in the corner.
Okay, and so I think most of you are aware that we're going to do another spring learning session, happening over the spring break at the University of Utah. So if you came to our last one, same place, same overall experience, we hope, without so much traffic getting up there. If you didn't make it to the one before, we encourage you to come to this one. It will replace our regular meeting. So March 15th is that third Wednesday, and it'll be at approximately the same time, a little bit longer. And one of the things that we're really hoping to do, and that'll be happening right after this meeting, is that I start really working to get in touch with insurers with some questions that we solicited from you guys. And thank you to those of you who responded with those questions. We really appreciate it. This is one more opportunity today to hear what questions might be interesting to you to have answered, important to you to have answered by insurers, and also to make sure that we include the right insurers. So we're certainly going to include and reach out to University Health Plans, Select Health, Health Choice, Molina, Regents, but I want to make sure that we don't overlook any other insurer that you guys might panel with, you might think is important in terms of your work and your practices. So this is an opportunity to check those names out right now. I can tell there. Okay, great.
I think state Medicaid.
Great. Any others?
I think looking at the Medicaid ACOs, so any of the ACOs that would be
Right. So our goal really is to A, reach out to them with questions and hopefully get some meaty, real answers to those questions. And if not having those answers ahead of time, to actually ask them to come and be willing to answer those ahead of time. So I don't know what the likelihood is of getting these insurers to have representatives at our learning session on the panel. That's our goal. So we'll work toward that. But if that's not something that they're able to do based on the schedule and so forth, at least to have some of those answers sort of talk through those. So that's the goal. And one of the things that we thought might be helpful is to kind of get your brain going is if there might be any specific examples in the clinical care side of things where you've had insurers perhaps deny something that you'd like to see them address, going forward in the future. So if you've had repeated denials around whether it's home nursing, whether it's around therapy, those kinds of things, that would be helpful for us as well if you want to share some of those things where you've run into some barriers or hurdles. So you can bring these up now if you'd like. You can think about it for a few minutes and we can potentially bring them up in our brainstorming session. Or you could always reach out and get back to me in the next day or two, and that would be a great thing to do as well. So this would be just really helpful for us as we move forward around the learning session. All right, so next we're going to have, actually I'll backtrack so I don't forget. Teresa, do you want to come up for just a second? Teresa has a quick announcement.
Information Center for Recovery and Spontac Pediatrics are partnering in a suicide awareness freshman on the 28th. This will be this is for parents, educators, teams. We're going to actually split the groups. Whether we're going to all meet together and then we're going to split where we have the adults and then also the teens. So we'd love to get as many teens there as possible. And the idea is really just to educate and also to give hope. So if you know of anyone or if you would like flyers, I'd like to give these out. I've got a bunch of them here before you leave if you can take them. And I have more if you need more. I can also send you an electronic copy. Attorney General Sean Reyes will be speaking as well, so it's going to be a really great event. Free breakfast. You or anyone that you work with or parents, teams that you know that you can benefit from this. Please. It's like schools as well. I am. Yeah, I'm there's a little bit, but yes, we are reaching out to them.
Great, thanks. Yeah, we'll be happy to help send that out via the list as well. Okay, so now we've got Shriners. Hi,
Deborah's running behind. I'm just going to pause for a minute.
Sure, you bet. Yes, we can do that. Okay. Don't let me continue on. Okay, all right. Great, so we'll come back to that. Okay, so this is our brainstorming time. So if not you have a second, here we go. So hopefully this is the opportunity that you guys have to bring your problematic cases, anything that you're kind of working to work through, find resolution to, and having a little difficulty. We can crowdsource here, we can network, we can figure out ways that we've already perhaps resolved similar things. We can also talk about new resources that you've come across, so we'd always like to hear the positive side of things as well, so please share those things. Anything at all, this is your time. So does anyone have anything they'd like to get a little help from or let the group know about?
I'm probably jumping the gun because it sounds like it may be addressed, but I have pulled my hair out for the last couple of weeks looking for transition 2-year-old young woman with severe CP into the adult world. I need help. There is nothing out there. I've talked to the rehab docs, a couple of the rehab docs at the U. I've talked to primary children. Today my call is going to go to the complex care clinic at Intermountain. We need help. And the other thing I'd like to put out there is a plea for home health, private duty nursing. We have many, many children that can't get what they need at home because there simply are not enough resources out there. There's no warm walking bodies. And it's almost, I don't know what people would define as crisis, but, you know, we have parents that have trach-invested children who are trying to take care of their families and take care of trach-invested children at home. They're not sleeping, people are getting sick, and it's really ugly. So those are my 2 issues for the day.
And I just want to second that 911 need out there to
Mumford this morning.
Did we have someone speak up on the phone? No?
Just keep talking.
Yeah, but there's only the 2 of us on. Oh, I wonder if we've got a little feedback going on. Well, hopefully that won't be too disruptive. So back to your 22-year-old with CP. Can I ask what the insurance situation is?
She has Select Health as a commercial, and she has state Medicaid as a secondary.
Anybody have any thoughts on that?
Well, I mean, I'll talk about it a little later. I don't know where they live. Farmington. Okay. So part of this work on a transition program, we have a relationship with a group called Custody Medical Center in South Jordan, and I think it's 4 medical physicians that are willing to take on the complex clinical care, and it's been difficult to get them to really respond. We sort of developed a little bit of a process, and I think I'm going to talk about it later, but that is a group that has people that would probably be good transition people, you know, that they would understand the complex, and they're certified in medicine and pediatrics. Oh, so they're not family practice. No, we need some that. Yeah, and I have another list, and it sounds like you guys can do something. And then just one other comment as far as the trade sex issue in Calvin. That is an issue that I've been working on with a hospitalist and primary children since April on the nursing, on the issue of nursing shortages. And this year, our goal is putting together a coalition, coming up with ideas how we're going to solve some of these problems, and they include getting people licensed other than nurses to provide the care, empowering primary care physicians as well. So there is a discussion going on about this.
One of the ways that we're looking at is some innovative ways to try to help this crisis. Looking at a home health aid mom is willing to oversee all skills needs, having an aid in there for 8 hours a day to give her time to where she can move. And we've made a couple of exceptions.
And it's my understanding that Utah law for this part of this issue, if we can prove that we've trained, say a CNA, if they can give medication, we can prove that we've trained them and that they're competent. They can function a trade. They can do those things that are considered skills.
I also know that there might be some, ethical and legal overlap there, but I'm just really, really concerned about what I'm seeing when I have parents that are begging for help. And commercial insurance typically doesn't pay for private duty nursing anyway, but they're calling me saying, help me, please, what do I do? So I don't know, it's an entrepreneurial suggestion.
But well, you get people trained.
We're really kind of on this, and there's a lot of, trying to get payments with innovative things for reimbursing parents, other family members, that since babies, a lot of the more babies that are being kept alive are sent home out in care because there aren't enough nurses because they're not doing well, and they're being split between a couple of waivers, the second waiver, and the medically complex waiver, and there's these issues. Gina's involved with this on this as well.
Yeah, they have legislators that are very concerned about this as well, and part of it is the lack of nurses because it's not respite if a parent can't go out to. So we're putting a lot on families that do have the help, and then of course the ones that don't. So we have legislators that are actually looking as well at the Nurse Practice Act and all of that because, I've been one of the families that, unfortunately, due to the technology and the needs that, once there's payment involved, it could only be a nurse, and which limited a lot of the, I think, capabilities. But we have to also realize that we want to make sure that they're in that field and that house to protect that child. So if there's a lot of different things, and part of it is the whole transition issue of having adult doctors that are willing and able to, is more willing and confident to take on these medically complex young adults.
Just a quick question, as we talk about legislators and we know that here in Utah or legislative session started in one of my experiences, because I deal a lot with kids at the end of life, is being able to have practicing nursing at the same time as hospice care, which is the concurrent care piece. And I'm worried that with the Affordable Care Act going away or whatever's going to happen there, that piece will be missed. How can we support you? How can we support you? We can be a very strong force if we choose to work together. And how can we do that? Well, I think anybody that's interested in being involved, if you want people from different aspects, is you can email me, Bruin at utah.gov. I'm sorry, C. Bruin, C-F-R-U-I-N at utah.gov. Tell me what your affiliation is. And we're already getting together, and the group's kind of growing. And our goal is by next year to really have research, to really have a plan, and then so we need to do something quickly. I think we've made an awareness of some of the legislators, but we still need to have some concrete things that we want them to come up with that. We're not doing that.
Great. So we're looking to expand also the comprehensive care clinic, which takes care of kids with trach vents. So we've asked for resources there. We're going to go through our foundation at Primary Children's to get additional resources like an APC and an additional care coordinator to help be as like a connector service for families so that they'll follow them across the continuum in the outpatient and inpatient setting.
So I just want to make sure everyone's hearing this. So,
Yeah,
yeah, and a little louder.
Okay, yeah, so Comprehensive Care Clinic is looking to expand their resources. They take care of treatment patients, and they're looking to add an additional APC and a care coordinator and a social worker to their service, and they would follow the patient in the outpatient and inpatient setting. So we're working on developing that process and what it looks like. So that's also a resource that's going to be available.
And what time frame do you think that'll be in?
We're doing it in 2 phases. I don't know the time frame. It's going to take a lot to get it there.
But at least,
But we're working on it.
It sounds like it's a solid thing
Yes.
that's going to happen.
Yes.
Will that include adults?
I don't know if Claudia has mentioned it, but Dr. Hoffman and myself are so comprehensive care really involved in, because they know the issues of trying to send the children home as well.
Right.
So that as we get the coalition up and going, I mean, all the voices have to be there, because so that the state can really see that it's not just a few parents or a few providers that are saying, we're at the cliff. We can't take another step without the help. So Claudia, does your group have a name? Can we call this something so that people know what we're talking about? When I send out an email, it says, get in touch with Dr. Pruitt if you're interested in helping.
I would probably call it, I think probably medically complex child coalition.
I'm just making
We're
some
gonna
of
make
that. Okay, great. Medically complex child coalition. So that's terrific, and you're working with primary children.
Yeah, so, I'm working, so one of the programs we have at children with special healthcare needs is that's called the tax dependent waiver, and when it was started 20 or whatever years ago, a number of kids could be put on it based on being on training events, IV, feeding, a bunch of stuff. So because there's so many kids now being alive, there's so many kids going to get paid price or events, stuff like that, there's only room for price bench kids, and then there's a certain number of slots that are left over for specific medical problems. So there is a waiting list, almost half as long as how many slots there are. So it's really terrible. And the other thing about the kids is they don't, once they're on, they don't go away. They're like 30, and in a sense that may not be fair. We need, we got to figure out a process where there's transition to another waiver or something else. There is nothing else. And so that's the issue. And then there's more coming out all the time. We have a lot, younger and younger with problems. And it's really a crisis. It's a combination of producing more, not having enough spots, and not having not having qualified people to actually help their families are left to it by themselves. And if they're not on a waiver, and if they're not on Medicaid, like you mentioned, their insurance don't cover home care services. So it's really bad. I mean, it's really bad. The other important thing to remember is that it's not that many children. Say it's not 200, 250. They take 50% of the hospital resources and the cost of hospitalization go to these medically complex. So if we focus on keeping them out of the hospital, we focus on saving a lot of money. So that's very important. Thank you. Nothing great. According to Michelle, Michelle's at the hospitalist that works with me, and she said they just cringe and almost cry every time they have to send somebody home. So it might be good to even just like hospital worker, they have training where they have to make it every month. That's what we have. I think that's the goal is that, but also great. Yeah, they need to be trained family members. People think, time for there's monitoring. If there were enough waiver spots and they qualified, in some states they automatically qualify if they reach certain goals. In our state, we have a limited number. So if they qualify, they would get it. Now they're having to take off of work and they're not getting paid. So it's bad. Yeah.
So I just want to start with Dr. Florida saying there because I just want to, chime in on this because I manage the credit union nursing cases and I have roughly like 60 of them. And I would say 1/3 coverage of private duty nursing right now. I think that is really bad. And I've had one case where the mother wanted her daughter to be at home with her, had been at home with her, and she just had no fear, and she was so complex, she had to be, institutionalized pretty much. And it was just heartbreaking. I have single dads who are, doing all these years, and these are our trade-fine kids. These are kids with travesty waiver, and there's not enough nursing out there. But on top of that, these kids are big adults now, and they're sloppy, and they're messy, and these are pediatric home health nursing agencies that, these nurses are flying in for 150-pound, sloppy trach, so they're not signing up for these cases.
So I have to jump in, and I don't mean to, as a parent of one of those, it's hard for me to hear that my older child is sloppy trained, and I get it.
Sorry, that's a nursing.
I know, but you and Claudia did say that there is no place for the older kids to go because these are pediatric nurses. That's what they said. That's what they. And so I just meant that it's hard for a parent to hear that, and it's not. I just want to.
Yeah,
and I think the training issue, families are the ones that are training the professionals. And I don't think it's a training issue with families. We actually do get some pretty good support in primary before going home, and they have set up informal support groups and such. It really is back to what Nancy and Claudia are saying is, even with pediatrics, it's hard to keep nurses in home health because you're going into a home where we're trying to keep a home environment. Some of us are very hard to deal with, and nurses run the other way, and that's just the nature of it. It's personality, and it's hard work for nurses. So that's where I think with just some of the ideas like Nancy was talking about with having some aides and some supervision, all of these have to come together because there's just not.
And so home health agencies being able to take our
Yeah.
Would be another option.
And so, and it's not just the trach. We as parents know as our kids get older and such, nobody wants to change our 20-year-old diapers either. And it's very hard as a parent to know that nobody wants to help your child at a certain point. So it really, we're like I said, we're on the cliff. Sorry, too near and dear to my heart, but it really is. Thank you for what you're trying to do, and I know Claudia and Dr. Hoffman have just been amazing at trying to move things along. Thank you. You don't ever have to apologize. No, I do, because I didn't want to sound like I was.
Without your passion, without your heart of direction, another point to training. Some of these babies that are coming out of the NICU or primary go to South Davis or Down Home Specialty Hospital to get excellent training, excellent transition. We want to support in all areas, but we are struggling, and I feel like the private duty nursing folks also don't get enough medical support, and I don't know how we can change the structure of that. And again, back to what I fight for all the time as far as hospice support and maybe families being able to have that concurrent care, even when they have commercial insurances. If you've got a private duty nursing in the home, they don't have any hospice training, and if this concurrent goes away, then we don't have hospice support management. We need to find a balance. The private duty nurses need more support because they're out there on their own, basically. I've had them calling me for pain control. One of the things that I did from an insurance perspective is I have a child who has transitioned between primary children's South Davis and home and primary in South Davis and home. And she's quickly running out of the benefits because they don't qualify in this particular child for Medicaid, okay? Any waivers, nothing. He's not trach or benefits, but he does have fatal disease, and he's really end stage right now. But what I said to the parents is, look, you have, in your particular policy, you have 90 days where we could provide private duty nursing, but I can't give you 90 days of private duty nursing. Would you be willing to train family members to come in and care for him? He has a G-tube. He's got 57 medications. I mean, he's pretty complex. But what if Select Health could give you 4 days a week for that 90-day period, and you take 3 days a week? You train your family members. You do whatever you need to do. So now we have extended that 90 days to that 4 days a week. So when we're looking at creative ways of trying to solve problems, this is a way to engage the families, keep them engaged, be able to give them a little bit of rest, and be able to still provide the professional aspect. And it was this particular case that made me say, we simply don't have enough resources. But I think we really have to start thinking outside of the box and getting creative in how to expand and extend those benefits. And this family was more than willing to do that.
So what is your Select Health's ability to do a creative solution like that? And what are other insurers able to do?
Okay, so I'll tell you I'm a little bit of a rogue. You probably have figured that out. I am a troublemaker, there's no question about it. My husband says, when I say think outside the box, he says, you don't even live inside the box. So I'm kind of that nurse without boundaries, you know. But I mentioned to my medical director and said, this is ludicrous. We cannot make this meet. He doesn't have this particular physician, he doesn't have a lot of pediatric background, and so he was really having a hard time understanding, well, if this child is in stage, why are we still NG feeding him? Why are we doing this? Why are we doing that? I looked right at him and said, because it's a child, and he can't speak for himself, so the parents are trying to be parents. Okay, Pat, I get it. So, I mean, I did have to kind of slap him around a little bit, respectfully speaking, okay? But I said, can we do this? And he said, if you can get the family buy-in, do it. So people are willing, if we can present the case, if we can figure out a way to help share the load and still stay within all the regulatory requirements and the financial. It's so complex. We've talked about it here. But I think other insurance companies, I don't know what they do. The advantage that I have is I am the only commercial pediatric care manager at Select Health. I get to do kind of what I want to do sometimes.
Please stay there for a while.
But I'm just saying, it's that kind of creative thinking. And I even went to, I've been to 2 of this child's care conferences, one at Primary and one at South Davis, so that they knew who I was, so that they could contact me and say, okay, this is where we're at, this is what we're doing, this is where we need to go, here are the limitations.
And so could some of the other folks in this room potentially reach out to the care managers, their patients' insurers, and suggest some of these
I
kinds
think
of things?
they should, absolutely. I don't know what other insurance companies do. I just know what I'm able to do, and it's tough sometimes because, like I said, I'm pushing that envelope constantly, and I understand that. And I've been told no a couple of times, but if we don't start challenging certain things, we aren't going to solve this problem. I've been reaching out to insurance, care managers, case managers for years.
I hope this is the kind of conversation that we have in March at our learning session too. This is great.
Mindy?
Yeah.
So I appreciate the insurance people that are here. The sad thing is there's 2. Is that right? We have 2 here. And okay, this is the bottom line of all of this, unfortunately, comes down to money. It's money from the insurance companies that they don't want to pay out. It's money from the physicians who take on this load that the reimbursement is not anywhere near compatible to the time and effort and energy spent on these children. And shame on us, all of us, because these families and I'm passionate too. I mean, I've had family members, but shame on us that that we are allowing these children and these adults that these parents have had to deal with from birth until they're into their adulthood, that we don't have more out there. And it's just like I've had numerous parents say to me when I've called them and say, oh, sorry, no, your insurance doesn't cover, no, sorry, no, sorry. And I've had them say, then why am I paying these premiums? Why am I paying all this money? You know what? Maybe I'll just quit paying my premiums, save that money, and hire my own people. Pay them, you know, something to come in and help me take care of these kids. And so, and I fought with insurance companies. I mean, literally just slammed the phone down on the desk, you know, because I know it's their job. I know that it's their job to try not to. But I even had an insurance company say to me once, well, you know, premiums and deductibles wouldn't go up if people didn't use their insurance. I said, oh, okay, well, I'll pass that on to my special needs parents. I'm like, really? Like, something's got to happen, and I don't know, like, do we all need to, like, head up to the Capitol and stand on the steps and say, you know, bring our folders of our patients and say, look, these are the families, these are the children, these are the hardworking parents that are, you know, trying to work and support their other family, and I don't know what to do. Sorry, I just had to vent that, because I think that's the problem, is it's the money. On every aspect, it's the money.
So the best thing to do is, like you're talking so passionately, call your personal representative, because even if they don't sit on some of these committees, the more education, the better, because there's still such a stigma of families of children with special needs and Medicaid, and you know, there's still so much education that needs to happen that, you know, these are not families that are trying to take everything they can. These are families that are trying to survive. There is still stigma about what some people think as quality of life, and we have to get past that, because it's those, you know, it's those that are living it that's, I mean, it's going to have to change on an individual basis, but it really is, when we do legislative work, that the more you can talk to your personal representatives, give them the stories of your patients and such, and then encourage your patients to call them and just say, you know, I know it's scary, and we do this all the time. We do a lot of trainings with families, but just to call and introduce themselves. That's it. Not, you know, they don't have to know any numbers. They don't have to know how a bill becomes a law and all that. It's just letting our representatives do their job and know who their constituents are and what the big issues are. And with that said, I think our state has tried to do quite a bit. We are still one of the most conservative states when it comes to some of that. But really, we're going to all have to watch very closely as we go on, because it really is a federal issue that, when it comes down to it, on what are we going to do so that health insurance companies can stay in business, that people are getting their needs met. And because we've heard horror stories. I mean, unfortunately, I don't have my children anymore, so I'm not living it like some of my staff and such are. And I just, when all of this happened, and listening to the fear that's going on in this office, that every parent, or every consultant and staff member in this office is a parent of a child or an adult with disability, we're walking on eggshells, waiting for the next, you know, foot to drop. So I just say, make it known that it's not just families, or not just providers, that all of us are really trying to help children and families and adults, that you care just as much as a provider. Because I think that's where, if it was one talk, the rule of thumb, when you call here locally, one person is considered 10 people calling. At the national level, depending on the issue, it can be one of their constituents. They mark it down as that's happening to 100 others in that area. So one voice can really make a powerful difference. Tina, do you think we might be able to have one of those trainings for, as a, an option, like a non-normal meeting, but another date for this
I
group.
think I call it the coalition. People do surveys. They do a wonderful training.
Wonderful. Okay. I'm excited to hear all the passion in the room. It's the right time. So particularly if we have a period of time since the Utah legislature is about to convene, it's not the ideal time to try and launch a new thing. You gotta be prepared. You gotta bring it to their attention. But it sounds like Dr. Pruitt is working toward that, and we can come and work together with you if we're interested in spending some of our personal time on that. And we can make sure that you're aware of what those opportunities and avenues are, and also the best way to get your voice heard. All right, it's great. This GIA group is, of course, to be reckoned with. That'd be fantastic. Very good. All right, well, this has not been a typical meeting. Jill, is it okay if we put you at the end?
Yeah,
and I promise, at 10 to 10,
Yeah.
we will break for that, because this is I kind of don't want to interrupt some of this momentum. This is just fantastic. So with that said, let's talk a little bit about transitioning. More specifically, we've already touched on it, and it sounds as though we both need to be focusing on some of the practical aspects of this, as well as some of the policy aspects of this. And what I think I just heard is that if we can be creative and help try and incentivize families to work within the resources that they've got around them, as well as work with their insurance company in a creative way, that there might be some wiggle room. It won't be perfect. That really more home nursing, private care nursing is really needed, as well as paying for that care. But there might be some ideas there, and we really encourage you guys to provide those details too, if you've had some of those wins. So Claudia, I don't know, are you comfortable just sitting there? This is a very informal discussion. We are not putting anyone necessarily on the spot. But Claudia has actually been thinking about this, working on this in a variety of ways for a while now. And so I have I've got some forms up here, but I also have a link to the survey that that Dr. Pruitt put together. So let's take a look at this. And so,
this has been an issue, I think, for a long time for pediatricians and parents, I would say mostly, which is probably especially parents who had children with special needs, who are trying to find a provider that has given her the care as a pediatrician. So the thing that I thought was important was, at least the thing I felt like I could try and make a difference, was to try and get a group of these providers that were willing to take the kids that we want to transition. I thought that was a gap. I thought that we have a lot of information on transitioning through the medical home portal from the Utah Family Voices and stuff on how to do it, but yet nowhere to go or nowhere to feel comfortable with. So I came up with this survey and sent it out in September to the Utah Medical Association, and it was targeting internal medicine doctors and med team doctors and family practice doctors. And basically, it was a bomb. Nobody answered. 4 people answered. But yeah, it was a bomb. But also, there's questions up there. Just questions. Thinking about like what would make it better or easier for you to go on and take transitioning patients, and I think so. Again, only 4 people answered, so a lot of them didn't answer some of the questions. But we just asked, the last couple of years, how many of you transitioned, and then thinking about some of the obstacles that that more comfortable, or they take Medicaid, or they need more education on specific conditions. Overwhelmed by one of my big pushes has been, I was thinking, I was an internal medicine doctor for 90 kids, and I had a kid who had a 20-year history. What about these medical records? How am I going to request them? How am I going to look at them? I don't want to look at them. I just want like the most pertinent information that pertains to kids at this moment in time. And so I don't feel like there's been a very good system developed for obtaining simple medical records. So basically, I think one half of the emergency answer that was 0.5 for all of those. So one other thing that I thought was really important was I don't know how pediatric providers actually pick up the phone and say, hey, I've got this kid, and they kind of explained it, and I thought that would be very helpful if someone could actually pick up the phone and give information on the patient prior to transfer. And basically, that wasn't happening on our work thing. And I felt like they did say that it would make a difference if someone actually picked up the phone, you know, and gave us some information about the patient. And they would be more willing to take the patient if someone, if there's a formal process like precise medical records, simplified medical records, and someone calling, they, you know, yeah, I don't do this thing. Yeah, that would be helpful. Yeah. Remember that? Oh, yeah. Yeah. Oh, wait a second. The yes and maybes were 50% until the 2. So they all said yes and maybe. Both of them. And the navy was where to go. So, it went out to the survey block, the people who come back to the country. It's on a listserv for all the members who come back. I don't, you know, surveys aren't always so great, plus there's some, so, yeah, and then Medicaid, yeah, they just said Medicaid. One yes, and let's see, interested in being involved. Don't you know, involved in an effort to improve the resources and processes. And so that's really the end of it. And so I think it's, obviously I think the questions are really good and the asking. And the other group that I've been in contact with is the American College of Physicians. The president, I don't know if he's still the current president, Bob Mendelson, but overwhelmingly, that this group is, from their board, is extremely interested. So I believe that he said they were going to invite you to a meeting, and it should be coming out like in February, so I'm emailing him again to see what's going on. So, you know, I think it's a positive response. They're seeing these patients, they're going somewhere. So in order to try and make it a simplified process, you know, open the information we need to make it more comfortable for parents, and you know, we kind of have to work together. And so that's the idea that we came up with here, the group of MSU Jackson in Congress in South Florida. And so the Integrated Services Group from Children's Special Health Care Needs has gone out to meet with them twice. And what we did was we came up with a simplified form. I don't know if you guys are aware of the DOT Transition website. Is everybody aware of that? It's called DOT Transition, D-O-T-T, then transition.com. And it gives you all the information about transition, gives you medical forms that you actually personalize for your own practice. But what we did was, I think, picked out 1, 2, 3, 4 pages of the most pertinent information. And our suggestion then was to cover view is before you make an appointment with the doctor, make sure this information sheet is filled out. Either your primary care physician do it, or someone at Integrated Services to kind of help gather the basic information, which is really all you need to know. Like, the kids that are alive and stable, you really just need to know their most current medication, if they need their x-rays or consultants. You need to know what's kind of going on with them, which is the general kind of history. Follow-up. That's all that the current doctor really needs to know, and if they need to get further back information, then they can certainly do that. So we would suggest that they have these 4 pages filled out and then make the appointment. Try and really make it easier. I also have the name of 4 other veterinary doctors that I think affiliated with the University of Utah that they refer to, which are Philip Eisenberg, Margaret Solomon, Clinton Sheffield, Julie Austin, are they affiliated with your? Okay. So, okay. So those are, so basically what I'm trying to do, or Integrated Services is trying to do, is gather these names of these people that are willing to take them so that we have it as a resource for anybody that wants to use it, maybe on the medical portal, maybe, family voices.
No, you got to have a secret password.
Oh,
Right.
Oh, I see. So again, we are it's just, I can see why it's hard for the docs not really wanting to accept them, because it's, to me, the biggest obstacle would be the overwhelming amount of information. We're like, again, I don't have time to read it. I really need to know it anyway. I just need nutshell information, and I can maybe that explain their condition, or a link to what their condition, or whatever. And I think that makes it so much easier.
We did those forms after I talked to Chloe before, and they work really well.
Yeah.
You're not sending
All.
yeah, and so they're not so overwhelmed. Providers.
I really like the idea of combining the succinct summary with the personal touch, and maybe, the name and phone number of the care coordinator or somebody in the office that the new provider can refer to if they run into questions or whatnot.
Right. So we did something very similar 2 years ago, an observation of this providers in our area. We got no response, so you're in good company. However, we did, and we put a phone call in all the offices we reached out to. We did end up finding one provider in our area who was going to take on that we work with, but it really became developing a relationship with this provider, and a process that's in place where we can say, where I have somebody to call, or the physician has somebody to call, and say, okay, here's what you need to know about this kiddo. Let's set up an initial meeting, and then kind of very confidential handoff. A lot of our families are really up in transition. Transition is, I have found, talking English difficult, certainly. We have a family health workers now. Last year they can say that transition was their number 1 goal or project, as far as how it should be approached by decision, when to have go to the subject. And we have our patients that are very young, they want to know about it. And so this year's family council, again, without having, they had the previous project in front of them, and then they had the choice of what to do. Again, it's transition. And we have families that range from 65 years old to 18. The 18-year-olds, the families of 18-year-olds, they struggle with the transition. And find out a lot of things in a very roundabout way, because it's not approached systematically. And it's hard to come up with those systems when these plan appointments for these kiddos are already so long. I don't know. I can't have a soapbox about that, sorry.
And transition isn't just about transitioning to adult care. Transition for our specialty field is everything. Right now, I'm transitioning with a 16-year-old. That's different from when she was 4. So it's all the different pieces you fit it in. But sorry.
If families are interested, they want to know what they need to do, and they need that information when they need it, you know, and when they're ready for it. And oftentimes the visits are not the right, they're just not the right time to do that, because that visit's already been so long. So to have those right, go in a room and start having that transition, which was our, initially when we did a project on it, we thought, oh, that will be perfect. And of course it wasn't. It was just things that were way too long. So there does seem to be, I don't know, there's got to be a better way to transition. And so if you find something that works, please let us know. But it probably would be better, I mean, I'm not seeing the patients, but better to give information. I think it's the process, maybe. I mean, can't say this is exactly the same, but it's really the process. The other thing is, when you're thinking about, you're thinking about multiple healthcare providers, so you're maybe transitioning from cardiologist to adult or neurologist to adult. So there are other specific forms to the American College of Physicians. They have condition-specific tools. So say most people with a heart condition, you can elect, you know, certain questions or certain information that you need to speak to the doctor based on what their condition is. So there are condition-specific forms as well now, which is a good thing, I guess. But I think it's complicated again because it's not just a primary care doc, especially here. I'm designing the EMT and the yada yada. But I just figure get all the health information so that we try and get the basic information, and we try and send all of those to the providers, information. Or you let their primary care doctor decide, how to transition save their life. So, yeah, I think it's hard.
So back to a little bit, though, what Liz and Dusty were talking about, to even identify the families who are going to start needing to think about it so that you can present the information to them in an appropriate time frame because you're thinking about it and watching for the cues from them. I mean, how many of you guys do you have a registry or a list that you're keeping of your patients that are going to be approaching the transition years? So is it 14 where we really want to start thinking about this and talking more with families? Is everyone doing that part, recognizing that the options at the end of it aren't there yet, but are folks doing this now?
Are the pediatrician offices, do you guys have a process in place where you look at guardianship? Because that's an issue, and it's not consistently addressed across the board. They just assume, whoever that nebulous group is, that if you have a child who's 18 or 19 who's medically complex is coming in for, I don't know, let's just say gastrostomy tube, that the parents can say yes and do it because they're the caretakers or whatever. But in Utah, there's that funny window of they're 18, but the parents don't have guardianship, but the child can't speak for himself. So is there a process in place in the offices where that's being addressed? Because that might help with that whole transition thing.
We do. We actually started having conversations about that pretty early on, and one of the things I did was start questions. You saw parents go to this class, find out the resources, talk to them, and the people that have seem to have a good handle on what needs to happen. But then there are some people, no.
I'm the mother, I'm not the guardian.
Right.
I can see that, yeah.
So it depends on the family, but certainly having that conversation and where the experts are and to go to the experts.
Is the age seen in the pediatrician's office for transitioning 18 or is it 21? I guess I'm confused on that.
Depends
depends on your pediatrician.
Depends on your pediatrician. We're seeing a 27-year-old.
We have 30-year-olds.
30-year-olds.
Yeah.
30-year-old.
You guys, yeah. Condition in the family and the provider and the, all of the above. But, so there is that age of majority at 18, regardless of whether they're still in the pediatrician's office, is that if that individual does not have their own voice to make their yes/no decisions, then hopefully, you know, they've started the process. They cannot legally start getting guardianship until that individual turns 18, but that needs to be in place. We've had, again, some horror stories of an individual with spina bifida that, you know, he could actually, I mean, he was directing his own care, but he became very, very sick and cannot make the decisions for himself, and they would not allow mom or dad in to the hospital to even say. So we also help parents understand that there's limited pieces too on just helping to make medical decisions. If it's not medical decisions, maybe it's financial, but again, letting them know if your child now, you know, young adult with a disability has any situations where there's going to be some medical decisions, such as life or death decisions, there's always a good idea to at least have a consent on file and ask the doctor's offices about it. How often does your Family Voices do the help facilitate some of these? Right now, the focus is on person-centered planning and such. It's usually grant funded by if Guardianship Associates gets a grant, and will help facilitate those classes. But there is ongoing transition conferences throughout the state. They're usually listed on the Utah Parent Center's website. So they try to do them quite frequently. We're starting, the Family Voices guys are starting to help you transition piece to kind of give a little bit more to the families as well as some of the professionals on what pieces of information to have for that healthcare piece, not just the, you know, school and vocational and both rehab, but there's also, and I will make sure I gather all of this together specifically around transition and all of that, because we have a big conference coming to Utah in July that is in connection with the Utah Developmental Disabilities Council, Centers for Persons with Disabilities, and it's along the lines of, yes, there's guardianship, but there's a lot more options. So we're really, I think, as a society, starting to look at how can we still keep this individual with a disability having the most independence in decision-making process as possible. So we are co-sponsors of that conference. So I will get all of that information out to you so that you can send families or even youth and young adults and know that that's what's coming. So the conference is specifically for families and young adults. Okay. Great. That would be terrific to get that in their hands, you know, far enough in advance for the families to plan for. And then all of the transition conferences, whether they're the mini conferences or a class, they're open to all. I mean, we definitely, we are funded to serve families, but we have just as many professionals in almost every class. Great. Very good. Really helpful.
Hey, Mindy, one more thing. So even when we find a doctor that we can transition these kiddos to, if they can get there, they don't want to stay because those offices aren't trained to deal with them, and they don't have the staff to deal with them. So what they were getting from us, especially if they had care coordination in their office, they go somewhere else, and they don't even get a tenth of a level of that care. So besides finding somebody that will take them, getting the parents to agree that, okay, we're going to leave you and go here, I don't know how you pick up the piece of training for those either internal medicine doctors or staff, or like they have to be on board with having those services in place that we have to take care of those families, because if they're not, it just doesn't work. So it's like so many things to make it happen that it just almost seems impossible. possible. But
So we need care coordination of the adults.
yes, that's what we were just saying. So if the adult doctors can have care coordinators that we can kick these kids over to and let the care coordinator take over and just let the doctor know here's what's happening, that would be great.
A small order, right? All right, this has been great. Can I put you guys on the spot for just 1 second and have you say, at this point in time, who your clinic serves, so that they're aware that, I know that you're very, very new. I get that, and not well staffed yet. So say all those things.
So we're a small team, and we only have one part-time MD. We have a full-time social worker, care manager, pharmacist, and we're just day one started yesterday. So our main focus is on university employees and those affiliated with Medicaid. And so our drive is to find complex patients, kind of like patients we find out here, and kind of put them into our unique structure, where maybe we can only handle 100 cases right now, but as we find a good model, we can kind of grow with that. But as far as, adolescent kids, I mean, we don't really have any age restrictions, but at the same time, it's more of, we have trait criteria that they have to meet certain complex. Bernadette Crow. Family medicine. We're at the main hospital up at the University of Utah. There's a School of Medicine section that's called 75. We're sharing space with existing clinics. So again, because we're all new, we're trying to cut expenses, so we're saying, well, how can we kind of integrate with something that's already existing and just see how things work, because we're all about cost saving and increase educational health and everything. So it's kind of the best of both worlds.
So clinic 6 is Gen 8, what is clinic 5?
Clinic 5 is surgery. Well, so again, right now, we're more trying to figure out what patient criteria we're looking for, so we're kind of reaching out to different clinics. Here's who we are.
So don't call us.
Well, right now, if something goes wrong, then you might get overwhelmed. But no, that's the right idea. Right now. Right now. That's love the girl, so yeah, we have to know.
But I didn't have to twist their arm very hard to get them to come today. So our hope is that as things develop, that they will feel comfortable with us actually suggesting the existence of outpatient clinic applicants.
Patients too. There's no co-pays, there's no loss of idea. Hopefully,
People are referred to when they know you care. Yeah, they're not meeting the criteria. Then you have a network effect. You don't meet our criteria, however.
That's a great question. We should actually look into. Yeah, we don't know.
Right now, it's university employees.
University employees are spending and those are using.
Okay, so not Polina or Sweat.
No, not at this point.
The new Medicaid has to be their primary insurance, or can it be their secondary?
Primary.
Primary.
So the chair.
Are you billing that? The parents are still billing in the background, but they so they're seeing how much. But the patient.
Great. Well, thank you, everyone. I think this was a great set of discussions. A lot of good ideas. Did I? Oh, I'm not forgetting. 10 to 10. I'm getting things over to Schreiner. Thank you very much, guys. You gave us a lot of food for thought. We're going to try and compile all the good nuggets that came out of this for our resources of the month. We'll get the information from Gina around Utah Parent Center transition events throughout the state, around the conference that's coming up in July that you can let your families know about, around the other things that Utah Family Voices help to facilitate. The guardianship stuff sounds, pretty important, and it sounds like it empowers families once they've got that information. That's wonderful. We'll make sure that you have the links to the GOT transition site and the forms that Dr. Pruin feels has been helpful in her experience. Hopefully these are some things to think about. We're certainly happy to provide the links to the survey if you want to look through those questions and think about how to maybe incorporate some of those ideas in your own setup. We understand that this is incredibly difficult. Any way we can help. And feel free to reach out to one another too, whether it's one-on-one, groups, by virtue of the shared directory that you should have access to, or you can just always email the list. It's great. That's what it's there for. You're very welcome to email the list. All right. Okay. Let's get back to, come on.
Well, I'll introduce Deborah Watkins. Several of you. Again, my name is Jill Connor from Shriners Hospital for Children. This is Deborah Watkins. She's our director of our care management department in our outpatient clinic. And we started this great new clinic at the hospital, and she's going to give you some more information about it. And I also have some handouts that I'll pass along. Just really quick, I know we're short on time. Thank you for having me here. When I was first approached regarding teaming up with our city and wheelchair department in our facility about a car seat clinic, I thought, well, what does that have to do with outpatient clinic? Sorry, guys. So why are we starting this clinic? We've discovered needs. Families have come to us in clinic and say, we don't have any way to transfer our kids. Other clinicians, we've had to provide transportation for a lot of our older kids that don't have any type of car seat to and from appointments. And because of this issue, they're not getting out much, and they're staying pretty much homebound. We need to involve the physicians in this. We need to get the appropriate car seat for the appropriate child. We also, with our car seat program, they get a pretty thorough medical evaluation from our pediatrician. Physicians also need to be involved because of the insurance aspect of it. There's no question for insurance company why kids need car seats. It's finding that niche and being able to present it to the car seat, or present the car seat to the insurance company so that they need anything over and beyond what is normally purchased. So our mission, it definitely fits within our mission to provide the highest quality of care to children without regard to race, color, creed, sex, disability, national origin, and especially without any regards to pay. Our target population is generally the older population. Regarding, all of the infants, if they have a syndrome or anything musculoskeletal, you can usually find something that will work for them. The problem becomes when they're older and they're bigger. Some of the diagnoses that we specifically look at for this clinic: cerebral palsy, osteogenesis imperfecta, skeletal dysplasia, and genetic syndrome. This is not all inclusive, but this is just kind of an idea of what we're looking at. What we offer in the car seat clinic, we have in our city and wheelchair, they've gone to a state certified program in car seat safety for quite a grueling course on the state exam, certification, and have to do continuing education and things like that. We have a physical therapist, we have occupational therapy. Our car seat specialists actually go out and inspect the cars. They check and see if there's any recall safety issues with the cars. They check the car seats and make sure the car seats are actually
not recalled. We've had some car seats that have been recalled. We provide a lot of education. One thing that we do is we bring the parents down with the car seat, and we instruct them how to put the car seat in. And they have to actually install it themselves so that we know that they're doing that correctly. We also have pressure mapping, and I think Jill touched on that earlier, so that we can make sure if we need to get a customized car seat for a patient, that we can do that. Our car seat clinics, the fourth Friday of every month, Shriners Hospital for Children here in Salt Lake City. We do have a number here that you can call if you have any patients that think that would benefit from that. Criteria is they have to fit criteria for being a patient at our facility, have to have neuroskeletal muscular problems, and or orthopedic issues. So we've actually only had one clinic so far. We saw 3 patients. With those 3 patients, we found 2 safety recall issues with the actual belt that they were using to fasten in the car seat. We actually took a seat apart to find the correct belt, and in order to do that, we had to use the owner's manual to find that. A car seat was being used that was way too small and that had been recalled like 3 or 4 years ago. We had another kiddo that was spinal bifida, so we did our medical evaluation on this patient and found some PQs on him that needed to be addressed. If we find or discover a medical issue that's not being looked at and that we find that needs care, then we'll refer out to the community, try to find a primary physician for this kiddo that we can work with. I wasn't excited about it, I'll be honest with you, until we actually had our first clinic and I saw the need. Parents that are pretty fatigued that have a kiddo that's like 90 pounds, they're picking them up out of their wheelchair, putting them in their car. I mean, it's just have a lot of sympathy for these parents for sure. Any questions or?
So how about insurance or anything like that, like cost?
So what we're finding is there's a big disparity between what the insurance will put out and what these car seats cost. A lot of these car seats, especially when they're custom made, you're looking into thousands of dollars, $4,000 or $5,000, $1,000. Reimbursement, even with Medicaid, is about 10 of that. So there's a big disparity. And we'll do everything in our power so that we can get a car seat. One thing that's really good about the Shrine organization is it's all about the kids. And if the kids need it, they do everything that they can do so that they can have what they need. We can do special fundraisers in the community and things like that, specifically for these car seats. And I'm anticipating it working similar to our wheelchair and seating, whereas as kids outgrow things, they trade in and we just reuse, refurbish. Another thing that's very good about the Shrine is they're very, very generous with their funds when it comes to getting what the kids need. Our wheelchair and seating department, their budget for equipment is based on need. And so it's a really good combination for us. And so I think that we're going to be able to help a lot of kids in the community, help so they can get out of the house more, they can experience life, and they can just be safe on the travel.
So if they do have, say, a primary and a secondary, can that cover the cost?
Yeah, we will do everything in our power to do that. When the economy went bad, as Jill said earlier, we started using insurance. And so if they have insurance, we will bill the insurance. If they have a copay and it's a hardship on them, we bring them in, we have them apply, for the programs that we have, and we just go forward. I can't say that we don't have parents that need to pay something, but I will say that we work with every single patient on an individual basis, look at what they have in their hardship, and we do absolutely the best that we can do for those kids to things that they need.
Do they need a clinician referral or can parents self-refer?
Parents can self-refer, and we just have to make sure that they fit criteria to be a patient under center. And part of our policies is that they have to be seen in clinic before they can go in as a specialty.
That's another reason why we brought in a pediatrician. They see the pediatrician first, and then in that same appointment, they do the feeding and lecture. The A clinic. We see patients to their 21st birthday. However, we only see patients, new patients, up until the age of 18. After the age of 18, if they haven't been seen at times, we usually can't take them. Otherwise, it's a very extenuating circumstance, and it has to be taken out there for further.
When you say after being an established patient, so if they haven't been seen at your clinic ever, we could refer them just to the Car Seat Clinic and they would see your pediatrician?
Yes.
But if they're already seen there for orthopedics or something like that, then it would just be an automatic referral.
Right.
Okay.
And people can self-refer. That's kind of the beauty of it. It used to be that you used to only get into the Shrine system if you were had a Shrine member that presented you to the board. It's not that way anymore. So we just need to make sure that the patient fits that medical criteria for being a patient at our facility. But parents can call in. We have lots of parents that call in and say, hey, I've heard about this, program. Can I get involved? We do screening. We bring them in, and it's actually a really good thing. I think it's the care manager's heaven looking at the Shrine because there's a lot of things that you can say yes to with our patient population that you can't anywhere else.
If they don't currently use the Car Seat, then do you recommend one that would be appropriate?
Absolutely. Mm-hmm.
So if they come in, they don't have a Car Seat,
Yes.
make the recommendations.
Yes.
Okay.
Yeah. And we will actually, we have a huge, of course, resources for Car Seats. We will look through and they'll decide kind of together. But I mean, we have an ethical responsibility to these kids when we bring them in to make sure that they can travel safely.
Because I'm familiar with Shriners Hospital, I want you to know as a bad person in the dark side of healthcare, I do refer some of my pediatric special needs children to Shriners because I know that something we will pay for that they can get at the Shrine. So
And that's our mission.
it's a good community kind of thing, and I think the mission of the Shrine is fabulous.
I kind of do.
Thank you so much.
I have more of these if you guys want to take some back. And if you need additional copies of these, please email me and I can arrange to send them to you. And then also with your packet, this talks about some other a small list of some other conditions that we treat. And then in the back of our Leaders in Care, it talks about more of our specialty clinics that we offer. And this list continues to grow, so we will get to see as we have new clinics come on board. Thank you.
Great. Thank you very much. So thanks everyone for coming. So don't forget about the James Mason Recovery Breakfast on the 28th, and we'll send out information on that. Watch for an email coming with the contact information from those nice young men who were here earlier. We hope you'll be willing to spend about 15 minutes talking with them at your convenience for your next week. And it might take us till Monday to get out the resources of the month because this was a big one. Thanks, everyone.